Great pleasure actually to chair this session on the surgery track in the second session. And it also gives me great pleasure actually to welcome three eminent speakers from around the globe. We shall have three presentations. The first presentation is going to be delivered by Professor Enrico Babini from Italy, in the title of Ablative Treatment in Thyroid. And the second talk will be given by Dr. Muhammad Al-Qarani from Saudi Arabia. And the title of his talk is When the Thyroid Crosses the Sternum. And we will conclude this track by a presentation on successful parathyroid surgery, which is going to be given by Dr. Wafa Al-Kayali, again from Saudi Arabia. So I will introduce Dr. Babini, who is actually an eminent professor of endocrinology in University of Rome. He's also a member of various actually regional as well as international thyroid and endocrine associations. He's very well versed in the area of thyroid nodules, as he has been actually one of the distinguished panelists when the guidelines in management of thyroid nodules has been drafted by the European as well as the international thyroid and endocrine associations. With further ado, I will let the stage to be given by Professor Babini. Professor Babini, thank you.
I am Enrico Babini, and it's a great pleasure to be here with you and to be able to talk about one of the exciting new frontiers in the management of thyroid nodules. We all know that surgery is the standard therapy for those benign nodules that become symptomatic after maybe a long time of slow but progressive growth. And surgery is definitely safe in high volume centers, but it's anyway expensive, is followed by neck scarring unless you use a non-traditional approach like transaxillary or transoral surgery, and in the majority of cases requires a lifelong substitution therapy. Finally, we can have some complications that are rare in excellence centers, but sometimes are frequent in low volume centers. And so we should have a management option that should avoid the cost and risk of surgery and prevent the loss of thyroid function and the cosmetic damage, while improving local symptoms. And the story started several years ago. We know that we had, during the 80s and the 90s, a few attempts to use radioiodine, mostly after priming with the recombinant TSH, for decreasing the volume of symptomatic nodules or nodular goiters. But we know that these initiatives were not very effective, and we don't have the availability of recombinant TSH for this purpose. And then we had the use of sclerosing agents, mostly ethanol, for decreasing the volume of nodules or the hyperfunctioning of autonomous nodules. But even these had some problem. And finally, we had the opportunity to test thermal ablation. The reasons, non-surgical techniques of thyroid tissue ablation were proposed during the last decades. The first one, in the 80s and 90s, was the use of radioiodine after a priming with the recombinant TSH. A few promising results were published for the reduction of huge nodules or goiters, but at the moment, this technique is seldom used. And nearly at the same time was proposed the use of ethanol injection for decreasing the volume or the function of thyroid nodules. And last, we had the proposal of thermal ablation with different sources, laser, then radiofrequency, microwaves, and last, HIFU. And now we have a valid, strong evidence that comes from single and multi-center prospective studies, real-world studies, prospective studies, randomized, and meta-analysis. And we can sum up all this data stating that we can have, after a single treatment, a decrease at 12 months that is about 60 to 90% of the initial volume. These results appear consistent among different institutions and are rather stable in the long term because we have nodule regrowth just in a minority, less than 15–20% of cases at 5 years. And all this is paralleled by the amelioration of cosmetic concern and pressure symptoms. Well, we can start with percutaneous ethanol injection. That is definitely an inexpensive, safe, rapid procedure without need of any relevant instrument. And we know that this kind of treatment can be performed as an office-based procedure, and that we have a persistent, striking decrease of cystic lesion over time. But we know also that when we have a dominant solid component, the reduction is much lower. And for this reason, in 2000, we started the age of thermal ablation with this feasibility study that demonstrating how a fiber optic and a laser source that were passing through a spinal needle were able to destroy a large part of a thyroid nodule. And this was the approach. Usually for large nodules, we use a couple of fibers, and this procedure with a pullback approach may strongly decrease the volume of large symptomatic nodules. But later, we had a radiofrequency with the electrode needles that were initially characterized by a large bore, but after a few years, we had the opportunity to use 18-gauge needles that were able, with the moving shot technique, of destroying large part of the nodules. Of course, we had the need of more skill because the electrode needle must be moved in different areas of the nodules in order to destroy nearly completely the lesion. And then microwaves, powerful, very effective, and able to destroy a large volume of tissue. The major limit was the large bore of these devices. And the treatment is characterized by, well, a modification of the moving shot techniques because the area of ablation of any single treatment is rather large. And so we have an overlapping area of ablation. Last, HIFU, the completely not invasive procedure that can be performed by operators without experience in interventional treatments because the treatment is guided by a computer and is based on the focusing of ultrasound in small areas that are destroyed one after the other and can reach valid results. Well, this kind of treatment is perfect for those persons who are, well, very concerned about the appearance of their neck, but generally speaking, the volume of distraction is much lower than the distraction that is attained with the thermal ablation like laser, radiofrequency, or microwave. Just 2 words about technology. Laser is the less traumatic because we use 21 gauge spinal needles. The area of distraction of the single fiber is a bit limited when compared to radiofrequency and microwave. Radiofrequency are very effective, as we told before, with the moving shot technique, but we use 18 gauge electrode needles, that is, electrode needles that are a bit more, well, intrusive. Microwave, well, at least until now, have a large bore devices, and the antenna have a blunt tip, and so frequently is needed a small incision of the skin with a lancet. And so, well, what can we say? What should we use? Ethanol ablation is perfect for cystic lesion, but is less suited for solid lesion because we have an uneven ethanol diffusion in solid nodules. Laser is quite safe, not traumatic, doesn't require a protracted learning curve for those operators that have experience in fine needle aspiration under ultrasound guidance, and is perfect for medium-sized nodules or for cancer recurrences in areas at risk. Of course, you need more time and maybe a repeated treatment for large volume nodular goiters. Radiofrequency is safe as well. You can use for treat even peripheral areas, achieving nearly complete destruction of the nodule. and so is very effective for large size nodules, but requires a more protracted learning curve. Microwave ablation is powerful and rapid, provides a large area of ablation, and is very good for large size nodules, less for lesions in areas at risk. HIFU doesn't require needle insertion and can be performed by operators without interventional experience, but is very expensive, has a rather low efficacy, and there are limits due to the location of the lesions that should be quite centrally located in the thyroid lobe, and so is better suited for selected patients that are quite interested in cosmetic concern. And all this was in some way stated by the first of clinical practice guidelines that was released at the end of 2020 by the European Thyroid Association. And here are the main recommendations. The first one is that thermal ablation techniques should be considered as a cost and risk effective option versus surgery when we are dealing with a patient with symptomatic nodules. Of course, should not be used for lesions that are still asymptomatic. Well, for mostly cystic lesions, ethanol injection remains the first line of treatment, and we should consider thermal ablation procedures only for those lesions that present with a large solid component. Thermal ablation of solid nodules can be performed with either laser or radiofrequency according to the specific expertise of the center, while we have a more limited experience with a microwave ablation, even if we are having plenty of papers from the Far East, especially from China. I would like to close my speech with just a few words about papillary thyroid microcarcinomas. We know that we are debating about the use of hemithyroidectomy versus active surveillance without any intervention. But we now could use a minimally invasive procedures in order to prevent the anxiety and the risk of a long deferral of surgical intervention, and so the need of a more extensive surgery, simply destroying the papillary thyroid microcarcinoma. And this age started as well in our center in 2011, and since then a great number of data are stating that these procedures are quite effective. And so quite recently we had a joint statement of all the major scientific societies dealing with thyroid that confirmed the opportunity to use, and the European Thyroid Association also added a very recent guideline on this topic. And I would say that certainly it will be important to have a second speech on this specific procedure. I want to conclude just with a mention of my good friend Claudio Maurizio Passella, a real pioneer of thyroid thermal ablation procedures. I thank the organizers and the scientific committee for this opportunity. And I do hope to be able to share with you this experience in person in the near future. Goodbye.
We need to move on to our next presentation. It gives me great pleasure actually to welcome to the scene Dr. Muhammad Al-Gharani, who is an eminent surgeon from the National Guard Hospital, King Abdulaziz Hospital in Jeddah. Dr. Muhammad Al-Gharani qualified from Saudi, and he trained in Canada, and he holds the fellowship of the Royal College of Surgeons of Canada. Dr. Muhammad is going to give us a talk entitled When Thyroid Crosses the Sternum. Dr. Al-Gharani, it's all yours.
Hello, everybody. At the beginning, I would like to thank the organizing committee for giving me the chance to be with you today talking about thyroid when it crosses the sternum. The other thing is I'd like to also thank the scientific committee for choosing this very interesting topics in this very prestigious meeting. So thank you, everybody. And I would like to tell you that I'm going to talk today about surgical part of retrosternal thyroid multinodular goiter. My name is Muhammad Al-Gharani. I am head and neck oncology surgeon at King Abdulaziz Medical City, National Guard in Jeddah. And I would like to share with you the topic today from my surgical perspective. Multinodular goiter is highly prevalent all over the world, especially in areas where patients or a population they are exposed to iodine deficiencies. But the retrosternal goiter is quite also the prevalence and or the incidence of retrosternal goiter vary in many countries, depends on many factors. But it varies from 0.2% to 45%. And the reason for this very wide variations of retrosternal goiter incidence is owing to very important reason, which is the definitions of retrosternal goiter. Unfortunately, there is no consensus in the literature regarding the definitions of retrosternal goiter. And each specialty dealing with thyroids, they have their own definitions of retrosternal goiter. Now, the most acceptable definitions of retrosternal goiter, at least from our surgical perspective, is that when the thyroid gland is thin below the thoracic inlet, or if there is more than 50% of the thyroid mass lying inferior to the thoracic inlet. So these are the most acceptable definitions from surgical perspective. I know endocrinologists, they have their own definitions, and also radiologists, they have their own definitions. But let's agree that I'm surgeons. I'm going to talk about retrosternal goiter from surgical point of view. So we accepted that 50% of the thyroid gland or the goiter below the thoracic inlet is considered retrosternal goiter. Otherwise, it's considered cervical multinodular goiter. Now, if we agree that 50% of the thyroid, if it's below the thoracic inlet, that is considered to be retrosternal goiter, I would like to tell you that in the literature, there is about 10% of those patients with this specific criteria, and about 45 or 50% of retrosternal goiter that reach to the aortic arch, they are treated through the cervical approach. So 90% of retrosternal goiter, if they don't reach to the aortic arch, they are treated through cervical approach. Mind you that there is an about 1 to 2% death rate, which is a very high compared to cervical approach if we do thoracic or sternotomy for removing the thyroid multinodal goiter. Now, before we go through the details of retrosternal goiter, I'd like to explore with you the types that we are dealing with. There are two very specific types of retrosternal goiter. The first one is what we call primary retrosternal goiter, and they are the primary retrosternal goiter. They actually developed in ectopic thyroid, and they're completely separated, as you can see in the left picture, that they're completely separated from the thyroid gland. The secondary, if we compare it to the primary, that means the thyroid gland itself extend below the thoracic inlet, and the intrathoracic part is completely linked to the cervical part of the thyroid gland. And these two types, they have very distinctive and genuine difference, and very important from surgical point of view, that if you have this primary retrosternal goiter, the blood supply actually is developed from intrathoracic components of the vessels, while if you have secondary retrosternal thyroids, the blood supply is from the cervical inferior thyroid artery, and this makes it a huge difference in the surgical approach. So those patients with primary retrosternal goiter are usually treated through a thoracic approach, sternotomy approach, while those types of secondary retrosternal goiter are treated most of the time, if I say 90%, they are treated with a cervical approach. There is no need to do sternotomy unless there is a very specific indications. Now, the symptoms of retrosternal goiter, strikingly that you have about 50% of patients with retrosternal goiter, they have no symptoms. And this is very striking and very important to remember, because do we need to treat those asymptomatic retrosternal goiter or not? And we'll talk about this point later on. But 50%, about 45 to 50% of those patients, they have no symptoms. What are the most common symptoms of retrosternal goiters? As you can see this slide, that respiratory distress, inability to swallow, cosmesis, and patient fear of cancer. These are the common indications of treating those patients or the symptoms of retrosternal goiters. But mind you that 50% or a little bit less than that, they have no symptoms. Now, if they have symptoms, right, as you can see, the CT scan, that the severe compression of the trachea, and this kind of complications may expose the patients or put the patient at risk of airway obstructions, either before surgery or during intubations by anesthetist. So it's very drastic complication if developed. Otherwise, most of those patients, they don't have any symptoms. Now, what are the evidence, if you are concerned with the treatment of retrosternal goiter, what are the evidence that we can withdraw from the literature to help us to make decisions in regard to the treatments? These are a few questions that, as a surgeon, I ask myself before I go before embarking on treatment of retrosternal goiter. First question is, does retrosternal goiter patients or thyroid goiter, they have higher chances of malignancy? Second question, what's the complication rate if we treat it with a thoracic approach? And the third question is, what's the best surgical approach? The fourth question is, what is the chances of recurrence and persistence? Fifth question that I would like to answer on an evidence base is the incidence of tracheomalacia, because it's very important complications in patients with retrosternal goiters. Unfortunately, we don't have a lot of randomized or almost zero randomized controlled trials if we compare cervical approach to thoracic approach. But let me start with the first question: does the malignancy rate appear higher in patients with retrosternal goiter or not? Cohen has a review in 2009, and he compared retrosternal goiter with cervical goiter, and he found that 11% of cervical goiter and 20% of intrathoracic goiters, they have a malignancy or carcinomas. The extensions of the goiter into the posterior mediastinum was found in 20% of patients treated with sternotomy and 0% with those treated with cervical approach. And if the thyroid goes below the aortic arch, has been found in 60% of patients with sternotomies and about 2% of those treated cervical approach. And we found also, and he found also that ectopic thyroid is about 60% in those treated with sternotomy compared to 0.9% in those patients treated with cervical approach. From this study, we conclude that the malignancy rate is much less in retrosternal goiter compared to the cervical goiter. And there are few indications to do sternotomies, which is the extension of the goiter into the posterior mediastinum, or if the goiter extends below the aortic arch, or if this patient has ectopic thyroid multinodular goiter. Now compare this to Mauricia when he reviewed about 247 patients, and he found that the retrosternal goiter has a protective effect against malignancy if we, after doing a bivariant analysis. But after doing a multivariant analysis, it seemed to be no difference. But from this, we conclude that, from this slide, we conclude that the malignancy rate is probably less compared in thoracic goiter compared to multinodular goiter of the cervical thyroid gland. Now, these studies, I make like a summary of some of the important studies that they compare cervical multinodular goiter with thoracic multinodular or retrosternal goiters. The studies done in 2004, 2006, 2002, 1996, and 2006 by, as you can see, Mauricia, Frankstone, Haidati, and Reeve, Hashimi, all of them showed that the rate of malignancy is ranging from 5 to 7%, except one study, Hidayati. He found that 21.6% of the retrosternal goiter, they have malignant neoplasm in the multinodular goiter. Now, I would like to remind you that all these studies upon review did not report whether these carcinoma are micro or macro carcinomas. So there is a limited evidence, I can say as a conclusion, there is a limited evidence suggesting that the incidence of cancer in substernal goiter is higher compared to cervical goiter. That means probably those with the retrosternal goiter, they have lower chances of having malignant neoplasm in the thyroid glands. Now, the second question is the complication rate of thoracic approach compared to cervical approach. There's a very important study that has been published in 2007 and in the United States, and they reviewed about 34,000 patients or 1,000 thyroidectomies. They found that 1,153, or about 3.4% of those patients, they have sternotomy for retrosternal goiter. And they reported that those patients with sternotomy, they have higher chances of bleeding, temporary recurrent laryngeal nerve paralysis, permanent recurrent laryngeal nerve paralysis, permanent hypocalcemia, and they have higher chances of death. They found in this very important study that this death is about 8-fold increase in the mortality of retrosternal goiter surgeries compared to retrosternal goiter of cervical approach. So this is a quite striking number or striking figure, that 8-fold increase in the mortality rate if we do sternotomy compared to cervical approach. This is another review that by Lin, and Lin studied the complication rate in the thoracic and cervical approach, and he found that operation time, hospital stay, permanent recurrent laryngeal nerve paralysis are higher. These are the only complication different in these two groups. All other factors and complication are very similar in both groups. So hospital stay, operation time, and temporary or permanent recurrent laryngeal nerve paralysis is higher in thoracic approach compared to cervical approach. Now, always there is a trend to do CT scan for all suspected patients with retrosternal goiter. And almost every case that need to be operated through sternotomy, or they have a retrosternal goiter, they have to have a CT scan. just to determine the approach, because not all retrosternal goiter, they have to go for a sternotomy. So CT scan is very important. Look at the left side, and you can see in this CT scan that there is a very separate nodule or goiter that is present in the posterior mediastinum. And usually this kind of tumor is difficult to be removed surgically, so sternotomy is indicated. Look at the right side, and you can see that the same but axial view showing the posterior mediastinal extensions of the multinodular goiter, and that necessitates sternotomy, which is not easy to be removed through the, you can see the picture, and almost reaching to the aortic arch. Now, Kilimian, he did a study, and he found that craniocaudal length of the tumor in the thoracic component more than 66 millimeters, and the volume of the tumor in the mediastinum more than 162 cubic millimeter on previous thyroid surgery are very important predictors for the approach of the retrosternal goiter, whether to do it cervically or to do it with sternotomy. Now, what are the high risk? Who are the high risk patients that need to have a sternotomy or thoracic approach? Those patients with extension of the goiter below the aortic arch, extension into the posterior mediastinum, dumbbell shape of the tumor, and thoracic components that is wider than the thoracic inlet. So the thoracic component is wider than the thoracic inlet. Those patients clearly indications to do sternotomy to remove the retrosternal goiters. Now, regarding decision making in regard to the approach or whether to treat or not to treat, unfortunately, we don't have any RCTs to help us to go for the best decision for those patients with retrosternal goiters. And the best available evidence is in the retrospective series. And also the decision making depends on if you have technology that help you to minimize the complication as neuromonitoring or not. These are important to study before embarking on treatment of retrosternal goiters. Now, the best surgical approach, as I mentioned before, there are clear indications to do sternotomy for retrosternal goiters. I don't want to repeat it, but just to summarize it for you, if you have huge intrathoracic that extend to the posterior mediastinum, if the tumor or the goiter reach up to the aortic arch, or if the dimension of the tumor is larger than the thoracic inlet. But the best approach has to have two important components. Number one is a safe approach, should be a safe approach. Number two, it should have a complete surgical resection. So this is a basic principle how to do or how to choose the best surgical approach for retrosternal goiters. It's clear and it's not difficult to say that extension posterior mediastinum, adherence to mediastinal structure, presence of ectopic thyroid goiter, extension below the aortic arch, all these are clear indications to do sternotomy or to do cervical approach for retrosternal goiters. But the choices of approach is very limited in case of huge posterior mediastinum, superior vena cava syndrome, and acute airway obstructions. These are we have no choice. You don't have to try cervical approach. You have to go from the beginning with intrathoracic or thoracic approach. I mean, sternotomy approach. Now, the evidence to choose cervical or thoracic approach, as I mentioned, we don't have any RCT. All the evidence are prospective. All the evidence, most of the evidence are retrospective, and they have few, probably 7 or 8 prospective studies, but they are uncontrolled studies. The evidence from these studies are weak evidence, but this is the only evidence available in the literature to help us to choose whether to go for cervical approach or to do for thoracic approach. Now, these evidence are very limited, suggesting that the cervical approach or the extracervical approach, I mean the thoracic approach, should not exceed more than 20%. So the sternotomy or thoracotomy appear to be more likely to be indicated in case of primary substernal or retrosternal goiter and masses that are larger than the thoracic inlet. So now, regarding the technology that will help you to minimize the complications of multinodular goiter treated with extracervical or thoracic approach is the presence or the availability of neuromonitoring. Neuromonitoring, especially the continuous neuromonitoring, although it does not prevent permanent recurrent laryngeal paralysis, but it helps to minimize the occurrence of temporary recurrent laryngeal paralysis. And you can see in the upper left that in the continuous monitoring, we hook our APS to the vagus nerve, and during the procedure, always give us a signal. You can hear the signal in the second video. This is a regular signal where latency and also the amplitude is recorded. And this is, I will just go back to the same, just let you hear the noise that we hear and tell us that there is a continuous monitoring and there is no complications on the nerve. This is on third video. If you hear this noise, that means there is a problem regarding the nerve, whether there's disconnections of the APS or there is an injury to the recurrent laryngeal nerve. So the neuromonitoring, although it's costly actually, about $1,000 extra to use the neuromonitoring patients with thyroid surgeries, but it really helps to minimize the temporary recurrent laryngeal paralysis, especially if you are treating huge goiters or intrathoracic goiters. Now let's talk about the approach of treating retrosternal goiters. As I mentioned before, if you have secondary thyroid multinodular goiter that extend, or secondary retrosternal goiters, 90% of those secondaries, they are treated with cervical approach, unless there is a clear indication whether it's extend in posterior mediastinum or reach to the aortic arch. Otherwise, 90% of them, they are treated through cervical approach. And sorry, you can see in this picture what we call spoon. We don't use a spoon in the dissection of the thoracic part of the multinodular goiter, but we use our finger dissections, especially if we ligated inferior thyroids, blood supply to the thoracic part of the goiter. Now, I tell you, about 90% of those patients or those cases are treated through a cervical approach. But if there is a clear indication to do intrathoracic approach or sternotomy approach, as has been mentioned before, in a clear indication, as you can see in this picture, this is the thyroid, the retrosternal goiter that has to be removed through a sternotomy approach. It's not amenable to cervical approach. Very huge, extend below the aortic arch, and has to be removed through sternotomy approach. Now, this is another patient who has a sternotomy also. You can see I'm pointing to the posterior mediastinum. I have to remove the posterior mediastinal components of the tumor through a sternotomy. It's not amenable for resection through the cervical approach. And on the left side, you can see the recurrent laryngeal nerve completely preserved anatomically and physiologically. And on the right side, the space left behind after removing the posterior mediastinal component of the retrosternal goiter. Now, what is the chances of airway compromise or complications post-resections like tracheomalacia of retrosternal goiter? It has been studied in these all retrospective studies. And to summarize this table for you, tracheomalacia in retrosternal goiter is infrequent. It's not common, although people feel that we have higher chances of tracheomalacia in those patients with retrosternal goiter, but the evidence does not support this conclusion. So usually most of the patients treated either cervically or with sternotomy, they have a very infrequent incidence of tracheomalacia, and they have a very fruitful post-operative period if done appropriately. Now, this is probably the last question I would like to ask myself and explore it with you, is should we treat asymptomatic retrosternal goiter? Now, To discuss this point, I would like to remind you that there is 8-fold increase in the likelihood of mortality if you treated patients with retrosternal goiter through sternotomy. In this review of 34,000 thyroidectomies, it has been well documented that the mortality rate is much higher compared to cervical approach. Although we as surgeons fear the following problems in retrosternal goiters. Number one is the progression of retrosternal goiter. Number two, the malignancy rate in retrosternal goiter and the complication from anesthesia or intubations. But it has been proved that there are no evidence to support these fears. There is no evidence to support that those patients with retrosternal goiter, they progress with time. There is no evidence to support that the retrosternal goiter, they are having a higher chance of malignancy. And usually those patients, they have no risk higher than usual for failed intubations. So based on these facts and evidence, Lindholm did a study in 2014, and he reviewed more than 200 patients. And he concluded from his study, based on the evidence that he found, that he recommended to observe this category of patients. So those categories of patients with asymptomatic retrosternal goiter, if there is no indication that they have a malignant neoplasm, should be observed unless they develop symptoms down the road. Now, this slide, just to tell you about a plea that has been added, a plea that has been actually announced by one of the great head and neck surgeon, John Laurie, and he asked all the time his thyroid surgeons trainee to have added qualifications to treat thyroid malignancy or thyroid tumors. And he also called individuals or surgeons that are treating thyroid with superficially as doublers. And the master of thyroid surgery is usually committed, and he treats thyroids from A to Z. And if I say what are the doublers are usually they jump ships. They treat different kind of tumors in the body, but thyroid surgeons is usually dedicated and usually burn ship. He doesn't jump ship. So there is a quite difference between many type of oncology surgeons. There are very few or specialty that are dedicated to head and neck surgeries, like head and neck surgery treating thyroid only, and other type of head and neck surgery, compared to our colleague from other specialty where they treated many kind of tumors in the body. And this is a plea for added qualifications, as John Laurie called in the past. In summary, I would like to remind you that there is no strong evidence to support the type of surgical approach. And the rate of malignancy or cancer in retrosternal goiter is not as high as you expected. Complication rate of thoracic approach is quite high compared to cervical approach. And the thoracic approach or the sternotomy approach, they have very specific indications to be chosen over the cervical approach. And also, last but not least, using neuromonitoring may help to minimize complications, especially the permanent, especially temporary recurrent legendary paralysis. And these, just to summarize what I have said, at the end, again, I would like to thank you all for your listening to my presentation, and also thank again the organizing committee, scientific committee, for giving me the chance to be with you today, and thank you so much. Hello, everybody. At the beginning, I would like to thank the organizing committee for giving me the chance.
Thank you very much, Dr. Mohammed Al-Gharani. I think for sake of time, as you know, we would move straight away into the third presentation, which is going to be delivered by Dr. Wafa Al-Kayali. Dr. Wafa is a breast and endocrine surgeon in King Faisal Specialist Hospital and Research Center in Riyadh, a very renowned, one of the best actually tertiary care centers in the Arab world. Dr. Wafa Al-Kayali is heavily involved in teaching. She has a managerial role as well as she's involved in research. She's going to talk to us this evening on the successful parathyroid surgery. Dr. Wafa.
My name is Wafa Al-Khayal. I'm a consultant of breast and endocrine surgery in King Faisal Specialist Hospital in Riyadh, Saudi Arabia. Our talk today is going to be about parathyroidectomy and how to perform it successfully. And you will see in the presentation that I will be talking more about the preparation more than the procedure itself. So our outline, we're going to talk about the introduction, how to diagnose hyperpara briefly, the indications, when to intervene surgically, and preoperative localization, as well as our approach. Primary hyperparathyroidism is a very common disorder, but usually found incidentally, and it's due to the overproduction autonomously of a parathyroid hormone by an abnormal parathyroid gland. Now, it's characterized by persistent elevation of the total serum calcium by elevated or inappropriately normal parathyroid hormones, and we need to know that the diagnosis of primary hyperparathyroidism is biochemical. Now, the clinical presentation is heterogeneous. They can present with no symptoms and incidentally found due to high calcium level, or they could have a variety of symptoms such as ranging between kidney stones to what they call abdominal pain. They can have psychiatric manifestations of anxiety, or they can also have bone loss, bone mineral loss, and then have osteoporosis and fracture. So there is a variety of primary hyperparathyroidism, which is normal calcemic primary hyperthyroidism. And this was recognized in 2008, where it is diagnosed with high parathyroid levels and comes with near normal total calcium levels. And this one is actually, when a study was done, found that in primary hyperparathyroidism, the majority were classic, but where we present with high parathyroid, high calcium, 16% were normal hormone, and 12% were having normal calcium. This subset of patients, usually I always call them the pre-phase. You can watch them, you can observe them. If they don't have any symptoms and they're not manifesting with any bone loss, some they will progress to have high calcium. So you can, the treatment really will depend on the patient's comorbidities, discussion with the patient, multifactorial. So again, we go back to how to diagnose primary hyperparathyroid. The total calcium should be there, the parathyroid hormone should be there, and the creatinine level. We need to look at the vitamin D level, as well as the 24-hour urinary calcium level, and we need to distinguish it with a rare form of familial hypocalciuric hypercalcemia. Now, the differential diagnosis of hypercalcemia is primary hyperpara, and that could be, the majority of cases are adenoma. We do have 85%, 50% can be hyperplasia with multiple glands, and of course carcinoma, which is less than 1%, and it's very rare. Usually, in my experience, it's diagnosed after the surgery, or after the fact, or intraoperatively, you find the adhesions and you suspect it, where I've taken by surprise. Sometimes when you present with a patient with very, very high parathyroid hormone, it can raise the suspicion. You should then work it out, do a CT scan, and see if there's any evidence of abnormally large parathyroid and an area of invasion. There is familial, which can be isolated MEN1, MEN2A, or MEN4. Of course, medications can cause it, thiazide, diuretics, and lithium. Chronic renal failure, aluminium, and then of course we get into the tertiary hyperparathyroidism, which is post renal transplant patients. Now, I'm going to present a case because I always think a case gives someone something to kind of base how we work up a patient. So we had a 57-year-old male who was otherwise healthy. He was referred from family medicine due to hypercalcemia. He didn't have any symptoms on history. He did have some neck surgery about 20 years ago for a cystic lesion. We didn't know what. He said it was a thyroid lesion. Biochemically, his calcium was 3.17. Parathyroid hormone was high, 351. His vitamin D was normal, and his 24-hour urine calcium was normal. Now, further investigation. So when you really have established hyperparathyroidism from the biochemical aspect, you look at for history of symptoms and complications. Now, then you can see, is the patient asymptomatic or symptomatic? If asymptomatic, you should do a baseline DEXA scan to look at for bone loss that can be still asymptomatic. If symptomatic, really go back for imaging for stones or for any fractures. So this case had his baseline dual X-ray. DEXA was showed osteoporosis. So what was the next step for us? Now, patient hyperpara has bone loss, osteoporosis. So do we intervene surgically or do we observe? So the indications for interventions or the criteria for operative treatment, the updated one is, first of all, if the patient came with symptoms, indication for intervention. Asymptomatic patients, then we look at the serum calcium should be either 1 milligram above normal, regardless of whether the symptoms are present or absent. 24-hour urine calcium is over 400 milligram deciliter, and increased stone risk by biochemical kidney stone risk profile. If the creatinine clearance is less than 60 milliliters per minute, and if his T-score was minus 2.5, the lumbar spine or the hip or the femoral neck or the distal third radius. Or when surveillance is not desired or not feasible, patient lives in a rural area, doesn't have access for a follow-up, and if the patient is less than 50 years of age. Now, as you can see, these are the indications for intervention. So if the intervention criteria is met, then we go for surgery, preoperative localization studies followed by parathyroidectomy. If these criteria is not met, you can see patient preference, patient wants to do surgery. We need to look at his perioperative risk factors, and we could consider his life expectancy. If it's not met, then we do surveillance where we do annual calcium. We look at his EGFR and creatinine. We'll do a DEXA every 1 to 2 years. And if he and we look at for vertebral fracture assessments and abdominal imaging for kidney stone evaluation. Now, our patient, of course, has the criteria. He meets the criteria. He would go for preoperative localization. And what are these? These preoperative imaging is really important because it can tell us if it's a single gland disease or a multi-gland disease, or it can be negative. And this guides to the choice of operative approach that we take. So if I do a preoperative image and it shows just single gland disease, then he goes for a minimally focused parathyroidectomy. If it's a imaging shows multiglandal disease or negative study or inconclusive, then the indication is to go for bilateral neck exploration, which was the gold standard years ago. Now, the preoperative localization varies really due to the diagnostic accuracy of each image due to differences in imaging acquisitions. Also, we have different patient population, basically due to single gland versus multi. And sometimes we found that if you re-image an initially negative result at high volume centers, the sensitivity can improve up to 92%. So what are the preoperative localizations that we know of? The first line, which has a high positive predictive value when combined together, is when you do a cervical ultrasound, thyroid, as well as the cervical, as well as technetium system EB scan with SPECT. Parathyroid 4D-CT, as you can see, I put it both in the first line and second line because there are reports coming up that it actually can function in the first line if it's available, or it can be second line, and it can be an adjunct for inconclusive the ultrasound or MEB scan, or it's found its role in persistent recurrent primary hyperparathyroidism after surgical intervention or in normal calcemic hyperpar. Petcholine, there are reports that it's now really, for me, any patient that the first line that went for my ultrasound doesn't show anything, as well as the technetium maybe scan spec doesn't show anything, then we send it for petcholine, and MRI parathyroid is again second line. And these are used when the first two are inconclusive or showing negative localization. So in our case, as you can see, he had a parathyroid scan spec using maybe we showed a parathyroid adenoma localized inferior and posterior to the left thyroid lobe. The ultrasound thyroid was done, as well as the cervical showed a small little lesion in the left lower pole. It didn't show any thyroid disease, and that's very important that when you evaluate any patient for next surgery parathyroid dectomy, you need to do an ultrasound thyroid to rule out any concomitant thyroid disease, because if he has anything like a nodule, it has to have an FNA, and if surgery is indicated, then we do them at the same setting. Because I have a case that just patient really came into me with hyperparathyroid. I went in and I did an ultrasound. I found a small nodule, was about 1.7, 1.8, recommended thyroids for an FNA, and FNA showed a patient had PTC. So patient is now going for both parathyroidectomy and thyroidectomy. Now, the type of surgical approach, we've done the preoperative imaging. We found that it's a single gland disease, so we go in and do a minimally focused parathyroidectomy. If the imaging had shown multi-gland or negatives, then we do again bilateral neck exploration. So our surgical approach, you really need to do a preoperative voice evaluation by history. If patient is not complaining of any voice changes, then you don't send him to the for any vocal cord assessment. If he does, then you send him. And that would maybe raise an issue if, for example, he has a left thyroid, parathyroid adenoma and has voice changes, and you send him and it has left vocal cord passes, that this should raise beep beep that it may be parathyroid carcinoma. Now, what is minimally invasive parathyroidectomy or minimally focused parathyroidectomy? It's really, it can range anything from a mini incision, about 2 centimeters, to a minimally invasive radio-guided parathyroidectomy, to video-assisted parathyroidectomy, to purely endoscopic parathyroidectomy. Its main approach is limited dissection, because it's focused. You know where you're going to go, and reduced incision length, be it doing with radio-guided or video-assisted, or putting in a small incision 2 centimeters. Now, I think what I wanted to say, in an expert hand, an endocrine surgeon mostly should have an adequate knowledge of the anatomy and the embryology of parathyroid gland, where it can go, mentally image. I always kind of mentally image the anatomy in my head where it can be, and I guide my incision. I usually do the mini incisions, about 2 centimeters. I actually use loops, so I kind of work in that small little field. So I do my dissections very fine, and it really is, you do it where the collar incision is. So you kind of do it in the same area where your thyroid incisions would be. You put it there because then sometimes there's something you cannot find, the gland, or you can convert it to a neck exploration. You just extend the incision to the same line. So that's where you place your incision. It should be placed where the thyroid incision is, the collar incision. So what is the absolute contraindications for the minimally focused invasive parathyroidectomy? If you've had previous neck irradiation therapy, if your localization studies for any reason are not, are equivocal, don't do it, because you will always end up with surprises. If you suspect there's a multiglandular disease, if you suspect there's a parathyroid carcinoma, and of course, if there is a family history of men or the patient is men, then we don't do 1 parathyroidectomy, we do 3.5. And of course, again, you have concomitant thyroid pathology. Now, relative contraindications, and in this case, our patient, he did have previous neck surgery, but to me, that wasn't a contraindication. He didn't have any voice changes, so he didn't have any contralateral recurrent laryngeal nerve, he didn't have any chronic failure, and he wasn't on anticoagulation therapy. In terms of for our parathyroids, we do use for our thyroid cases as well as the parathyroid, we do have the intra-up nerve monitor is there. And usually if I'm doing inferior, I really do find the nerve, and I usually find it there, to make sure it's okay. If it's in that area. If not, then I'm quite sure, because I have that the anatomy where it's going to be. If it's far away, then I don't look for the nerve. Now, it's really important when you do a minimal invasive parathyroidectomy that you use it with the intraoperative parathyroid assay. And that really makes your successful the operation more than 97 to 99%. Because the cure rate, it really has sensitivity to 8.6. It's really sensitive to single gland as well as to multi-gland disease. And what really it is, intraoperative assay, parathyroid assay, is simply you actually draw the parathyroid hormone. And the half-life of the parathyroid hormone is minutes, like up to 4 or 5 minutes, it's cleared from the system. So technically, you take one baseline assay, and then you take one after 10 minutes from the excision of the suspected epidermal. Some people will take baseline at 5 minutes, at 10 minutes, and that's the Wisconsin theory. I technically do baseline and then after 10 minutes from the excision. The other thing that is baseline, a lot of people do it from the time of induction when the anesthesia sleeps, they do this. I technically don't like that one. I prefer the baseline to be when I find the parathyroid, because the dissection around it really kind of, what it does is there's a lot of parathyroid hormone that's when you interrupt the gland will be secreted into blood. So if you take a baseline before you start, it could be actually low. For example, it could be 300. And if you do the excision, it can actually go higher. So that to me, I try to do, when I find it, I excise or I dissect around it, I tell them to take my baseline. And then after I excise the parathyroid gland, 10 minutes later, then we take the other one. And I find that's the way I do it. So whatever, I mean, as I said, there is baseline and at 10 minutes. There are different baseline, 5 minutes, 10 minutes, whatever it is has to be consistent. You need to know your hospital, you need to know who's doing your parathyroid assays. The timings have to be done the same at every time. So for our case, he underwent a minimal invasive parathyroidectomy. It was a small incision, 2 centimeter. His pre-excision parathyroid hormone was 1,225. And that was after I was excised because it was actually a large one. And after 10 minutes of excision, it went down to 54.9. His final pathology showed hypercellular parathyroid consistent with parathyroid adenoma. So in conclusion, parathyroidectomy is a definite treatment for hyperparathyroidism. Asymptomatic primary hyperpara is the most clinical presentation, and then that leads us to look at what is the criteria for intervention. Really, despite that we have guidelines, the rate of surgical treatment still remains low. Cervical ultrasound and the SPECT MEBI parathyroid scan is the optimal first-line strategy in preoperative planning with primary parahyper with a very high positive predictive value. Really, the parathyroidectomy, we need to consider the patient's life expectancy, the benefits that he will receive or she, the risk of the surgical complications, and usually in someone who does it in a high volume center, it's quite low. The medical comorbidities, and of course, the experience of the surgeon. It has really been known that the more that you do and the higher cure rates that you have, the better outcomes you have in parathyroid excision. Thank you.
Thank you very much, Dr. Wafa Al-Khayal, for a very crisp presentation. Thank you very much, all our distinguished speakers. I will actually start the questions and answer session. Enrico, thank you very much for joining us. I enjoyed very much your talk. And if I may just to ask you regarding the, you seem to be an advocate for non-invasive approach to treat thyroid nodules which are harboring papillary thyroid microcarcinoma. Do we have any sort of meta-analysis or randomized control studies that actually support such move?
Well, really, I I am interested because I just started this methodology, and so I am interested in it. But in my opinion, this is just one more tool that we have. It's just another option. That is, I still suppose that the hemithyroidectomy is the best approach to micropapillary cancer. But we know that we have at the moment also the proposal for just control, the so-called active surveillance. And my experience is that it's rather difficult to follow patients for many years without any kind of treatment. And so, well, when we have major contraindications to surgery, or when the patient doesn't want to submit himself to surgery, or when there are conditions like a contralateral palsy, for instance, well, in this case, we have also this opportunity. What can we say about the evidence? We, at the moment, don't have prospective randomized controlled trial. We have just a large series of patients that were retrospectively followed for up to 10 years after treatment. And the evidence is that we have a rather low risk of recurrence after a complete ablation. Of course, at the moment, a few studies are starting. We have a few studies that are starting in different areas of the world, but we don't have at the moment a prospective randomized trial. We have a few meta-analyses of large retrospective studies, but they are performed not on randomized controlled trials. The best we have are, well, matched series of patients. That is a propensity score matching between patients treated with thermal ablation versus a cohort of patients that is clearly matchable and that was treated with surgery. And of course, the risk of complication is lower with minimally invasive treatments. And so I would say that this is an evolving field that is very promising, and certainly, well, it's extremely less invasive than surgery.
Thank you very much. I have another question here, again to Professor Enrico. You have actually elaborated on the sort of various modalities for non-invasive ablation of thyroid nodules. There is a question whether there is any comparison between radiofrequency ablation and the microwave. If you could just enlighten us a bit more on those.
Yes, of course. As you have seen in my presentation, at the moment we have 3 opportunities for treatment of micropapillary cancer. Laser, and it was the first modality of treatment. Then we have a radiofrequency, that is an extremely effective modality of treatment. And more recently, we have microwaves. I would, well, stress which are the differences between these 3 methodologies. Laser has the advantage of the flexibility and very small gauge of the 21 gauge spinal needle that you use. And so you can put the tip of the needle nearly wherever you want. Radiofrequency provides a larger area of ablation that is a bit more powerful and has a a gauge that is between 18 and 19, and so is still not very traumatic, but is a bit more traumatic than laser. And finally, microwave. Well, until a few years ago, we had only 16 gauge antenna for microwave, and so it was rather intrusive. But now we have also 18 gauge, and a few devices have a less blunt tip. And so, well, the major problem of the microwaves is that they are rather powerful. And so you have to take care of the area of ablation, especially when you are treating, well, lesion in peripheral areas of the gland. And so in this case, I would say with a microwave and probably also with radiofrequency, you should perform an injection of a solution in order to insulate the thyroid from the critical structure that are close to them. And yes, we have a comparative study on a large number of patients, and the results, well, were nearly similar with the two techniques.
Thank you very much, Professor Babini. A question to Dr. Wafa Al-Khayal from Saudi. If you could just give us a bit more niche on the local experience from a tertiary center regarding the minimally invasive versus sort of open major surgery for parathyroid. Just in brief. Dr. Al-Khayal? We seem to have lost her, maybe because of some technical issues. A question to Dr. Muhammad Al-Gharani. Muhammad, are you there?
Yes, yes, I'm there.
Yes. Shukran lek, Muhammad. Thank you so much for such a very actual enlightening talk about the retrosternal goiter and the sort of pitfalls as well as the surgical side. What is the sort of, in your experience, the rate of post-operative sort of hypothyroidism, which tend to be a bit more actually common in patients with cervical approach when you treat such large goiter, probably just related to compromise of blood supply and what have you. Could you just share your local experience with that?
Yes, I think you mean hypoparathyroidism.
Yes, sorry, hypoparathyroidism.
Yes, definitely. Whenever you do extensive neck explorations, like in big multinodular goiter or retrosternal goiters, or if we are doing a neck dissection, whether central or lateral neck dissections, the chances of hypoparathyroidism is high. So in those cases, the usual percentage of post-operative hypoparathyroidism is about 15-40%. So in case of neck dissection, whether central, lateral, or big thyroid goiters, the chances are higher, maybe 60-70%. So in such cases, reimplantations of parathyroid glands in the sternocleidomastoid is the usual practice that I do. I chop the parathyroid gland, then I transplant it into the sternocleidomastoid. Even if the parathyroid looks okay, because with time, the devascularization will happen and ensure the hypoparathyroidism in post-operative period. So at least I chop one of the parathyroid glands and implant it in the sternocleidomastoid. I don't implant it in the arm, as our colleague from GS or surgical oncology endocrine surgeons, but I do it in the sternocleidomastoid in the neck. That make it easy for me if the patient develop later on adenomas or so on. So this is the usual practice. Yes, I agree with you. It's very high post-operative in those cases.
Okay. I don't see that we have got any other questions. Thank you very much, Professor Enrico Babini from Rome. Thank you very much, Dr. Muhammad Al-Gharani from Jeddah. And thank you so much, Dr. Wafa Al-Khayal from King Faisal Specialist Hospital and Research Center in Riyadh. Thank you very much, everybody, for attending this very sort of enlightening surgery track.
Many
thank
thanks.
you very much.
And
Everybody
I
have a
was
good evening.
honored to participate.
Thank you.
Thank you
Thank you
so
very
much.
much.
Thank you.
Thank you.